Hi everyone, my name is Angel and I'm going to be presenting on sort of the use of the Cox proportional stratified model for HIV survival rates based on an international cohort study from 1996 to 2013. So the full title of the paper that I'm going to be presenting is Survival of HIV Positive Patients Starting Antiretroviral Therapy between 1996 and 2013, a collaborative analysis of cohort studies. This 2017 paper published in the Lancet HIV was produced as part of the Antiretroviral Therapy, also known as ART Cohort Collaboration Project, which is an international collaboration across North America and Europe established to examine the prognosis of HIV positive patients initiating antiretroviral therapy, which I will now refer to as ART, as that is a mouthful. They have subsequently built a database based on this collaboration that includes information on over 100,000 patients and has produced numerous research papers devoted to studying the outcomes of survival of HIV patients within the clinical field. So let's talk a little bit about the purpose of this paper and the background of the paper. The background of this paper is based upon the premise that people infected with HIV have experienced vastly improved health outcomes since the 1980s. Therefore, in order to keep up with these improvements, updates were needed in terms of survival rates and hazard ratios, especially in light of sort of new and innovative treatments that have recently emerged. And so bearing all of this in mind, let's look at the specific research question that this paper aims to address. As mentioned previously, there have been vast improvements in the ART treatments targeting at lessening the impact of HIV. And findings from the previous ART collaborations project had reported that despite these improvements in the virological response to antiretroviral treatments, mortality rates 1 year after initiation of ART treatments did not decrease between 1998 and 2003. And so what this paper poses as its research question is picking up where that research had left off. It aims to examine changes in 3-year survival and life expectancy of patients starting combinatorial antiretroviral therapy between 1996 and 2013. So the data for this study, it was collected basically by the ART cohort collaboration over many years, and it contains combined data from 18 European and North American HIV cohort participants in the study. The study overall includes people that are living with HIV aged 16 years or older, who were started on combinatorial antiretroviral treatments between the periods of 1996 and 2010. For this specific study, participants had to meet the following 2 criteria. They had to have started combinatorial antiretroviral treatment with 3 or more drugs between 1996 and 2010 and had at least 3 years of potential follow-up. And then secondly, they had a baseline CD4 cell count, and CD4 cell count is a reflection of your lymphocyte immune system is responding or still intact. And so you had to have that cell count sort of present within 2 weeks to 2 months after starting the actual sort of antiretroviral treatments in and of itself. So what I'm going to do sort of now going forward is talk about a little bit about the methods and the baseline methodology of the project, and then introduce an interesting twist that was sort of introduced by some open correspondence to the authors questioning sort of their overall methodological approach. But firstly, let me establish sort of what the author's methodological approach was. Participants were observed and their status, so dead or alive, was recorded for 3 specific time periods between 1996 and 2010. And so all patients were receiving combinatorial antiretroviral treatments, or ART, but several different combinations of drugs had been prescribed across international cohorts, including such things as protease inhibitors, entry inhibitors, and sort of other sort of antiretroviral treatments. Therefore, several covariates were introduced to stratify the variables, as well as to control for some things that they were known to be strong influences of outcomes, including things such as sex, injecting drug use, which is described as the risk set, the AIDS status at baseline, so when they started the study, age of the patient, the CD4 cell count, which I've already alluded to, and HIV-1 RNA viral load at the start of ART, and that is exactly what it says, is the amount of virus sort of present in one's body. So those are the kind of the covariates that were introduced into the study. And I'm going to move on now to the actual statistical methods that they used. And so the Cox proportional hazard model was used to create basically these hazard ratios. And the hazard ratios themselves became sort of stratified by the covariates that I introduced on that previous slide. And so it was a combination of binary variables as well as continuous variables that were converted to categorical variables to create basically these hazard ratios to figure out sort of how the ART treatments had affected patient survival over the course of many years. So as I mentioned, Cox proportional hazard models were used to investigate the consistency of mortality trends across the subgroups of patients. And you can see the subgroups here. And so to create more easily interpretable and comparable data, the covariates that I mentioned were either binary or continuous were converted, the continuous ones were converted into categorical variables for ease of interpretation. As you can see here, age has been sort of stratified sort of across 5 categories, while CD4 cell count is across 4. It was previously noted that mortality is higher in the first year of starting ART treatments for HIV patients. And so hazard ratios were therefore sort of created for after 1 year of treatment, and then subsequently we were created for after 2 to 3 years of treatment. And what you see here on your screen is basically the hazard ratio by sort of strata of years after the first year of ART treatments. And as you can imagine, or as one would expect, basically, depending on when you started the treatment, the hazard ratios have declined with the improvements of the treatment overall. So patients that started sort of ART treatments in 2008 had lower all-cause mortality. And the first year after their ART initiation, they did patients starting ART in 2000 to 2003, as you can see here. So those adjusted ratios have definitely sort of gone down over that time period. So you can see here, basically in that first row, sort of if 1 is our 2000 to 2003 is our base year of 1, by 2008, that hazard ratio had dropped to 0.71 there. That was for that first year of treatment. And then sort of the next chart that's showing here basically is hazard ratios for the second and third years. And sort of those same trends are evident on those charts as well. All-cause mortality in the second and third years after initiation of ART was also lower in these patients basically in 2008 to 2010 compared with those in sort of 2000 to 2003. And these declines in mortality ratios were likely sort of related to improved treatment as hypothesized by the authors and presented in the summary here. And so sort of as you can see here, that trend continued for second and third year treatments, where in 2000, which is our base year, which is sort of a hazard ratio of 1, by the time you get to 2008, the hazard ratio had declined to sort of 0.78 if you're looking across that top line there. So as I previously mentioned, sort of CD4 cell count and viral load were known to be basically strong predictors of survivals. And so the authors basically tried to isolate these effects. And so what they did for the CD4 count, being that the higher the better, meaning that the body's immune system is a little stronger, they stratified for sort of these effects basically in the overall sort of comparison of hazard ratios across all strata. And so to fully understand the mediating effects of the response to the therapy, they added the additional adjustments to the second and third year analysis for the CD4 cell count and the viral load measured. And as you can see, that is reflected basically down there in that right-hand corner, where basically the second and third year sort of hazard ratios were additionally adjusted for CD4 cell count and viral load at that time. Both overall, basically, I think you can see, going back to sort of the mention of sort of using the Cox proportional hazard model to create the ratios, these cumulative hazard ratios were generated overall across sort of the first year and then sort of the second and third year. And what you can observe overall from the plots, that both adjusted and unadjusted models, the hazard ratios declined over time, showing the increasing efficacy of the antiretroviral treatments across all time frames. And so as you can see, as you work your way down those time frames on both the left and the right, basically that hazard ratio certainly declining sort of over both time frame that were measured here. Additional analysis were also performed, including sensitivity analysis to further test the model by adjusting for timeframes for those lost to follow-up. And those were then sort of used, those adjustments were used to calculate basically expanded sort of age projections in terms of expected age at death for men and women living with HIV. And as you can see, basically across these sort of life expectancy or survival times that were predicted in age bands of 5 years, survival overall was also increasing, as one would be expected, as seeing as it is sort of inversely related to the hazard ratios that we had previously mentioned sort of were declining over this time. So survival ratios, survival sort of rates sort of created here, and then conversely, we had just seen that the hazard ratios that were calculated there. I had mentioned basically that a Cox proportional hazard model was used, and as I mentioned, there was an interesting sort of reaction to this. A group of outside researchers from the University of Hull, which is also in the UK, as our collaboration is based in the University of Bristol, they took issue with the use of the Cox proportional hazard model, citing statistical concerns, and I'm quoting here saying that for combined heterogeneous cohort studies to be statistically sound, each cohort should be included in the analysis as a cluster. The Cox proportional hazard model used, however, assumes that all the effects should be simultaneously estimated within a likelihood function without adjusting for the heterogeneity of cohorts, which has some implications for the soundness of the results. So breaking this down, because that's a bit of a mouthful, basically, to address the nature of their modeling, what they were saying, what the outside critics were saying were, for a combined heterogeneous cohort study to be statistically sound, should each cohort be included in the analysis as a cluster? Also, should the Cox proportional hazard model assume that all effects be simultaneously estimated within a likelihood function without adjusting for the heterogeneity of the cohorts? So you can see sort of there the model for the stratified Cox that was used and which we should all be very familiar with. And the authors responded to this. The authors responded to this by breaking down the nature of their modeling, and they addressed the potentially between cohort heterogeneity, in other words, the clustering recommended by the outside researchers, by noting that they stratified their generated Cox models on the respective cohorts. In other words, the baseline mortality hazard varied amongst cohorts, while the model maintained a common effect of covariates across the cohorts. So in other words, the parameter estimates remained the same, but the baseline hazards varied as in a typical stratified Cox proportional hazard model. Thus, patients were stratified by their prescribed antiretroviral drugs across geographical locations, generating a stratified Cox model to mitigate any potential sort of issues with sort of the heterogeneity across the cohorts. Another issue that was also raised by the authors basically was this issue with the CD4 cell count and the viral load varying over time, and should they be considered as time-dependent variables? In the paper, as you may recall, sort of we showed you sort of hazard ratios that were estimated after adjusting for CD4 cell count and viral load at the baseline. And the outside researchers posited that as CD4 cell count and viral load vary over time, they should be considered as time-dependent variables. And an extended Cox regression is not an appropriate method. So what do they mean exactly by this? Basically, what they were asking is, should a time-dependent Cox proportional hazard model actually have been used? And as a reminder, basically, sort of a time-dependent variable is one whose value changes over time, basically. And in this case, it's basically they're asking about sort of CD4 count and viral load. And as a reminder, what an internal variable is a variable that changes because of internal characteristics or behavior of the individual. And due to the combination of both the sort of time-dependent variable and sort of it being an internal variable, the outside critics sort of counter that because of this temporal nature, would a joint time-dependent Cox proportional hazard model or a modeling of time to event and or longitudinal outcomes be a better tool for the analysis? And the authors also sort of subsequently responded to this as well. They had a completely different view about this. Based upon their previous research covering antiretroviral treatments, their rationale for not using a time-dependent model was that previous research had shown that the effects, so the covariates, of important prognostic factors such as CD4 count were typically consistent across cohorts, and that calendar time effects were consistent across subgroups defined by values of important prognostic factors. So in other words, the beta parameter estimates adequately captured any temporal elements if they existed at all, and no further adjustment beyond the stratified Cox was actually needed inside of the model. And I think that their sort of reply was somewhat justified, as if you could recall basically from the previous hazard ratios that were shown, basically those hazard ratios within that last column, which is the last sort of time period observed, their hazard ratios and the confidence intervals across these strata did cover a pretty small range of values between 0.70 and 0.90, sort of therefore somewhat justifying sort of the explanation of the authors in and of itself. And one last and quick sort of analysis, or I should say criticism, that was leveraged at the authors was basically that of non-informative censoring. The critics cited that the potential for selection bias was introduced into the paper based on informative censoring due to a high number of patients that were lost to follow-up having very similar profiles, and that they were tended to be female, younger, and people who inject drugs, indicating that their distribution in terms of characteristics for folks that were lost to follow-up were not actually reflective of those that remained in the study, leading to potentially selection bias and possibly overall bias results. The authors again sort of countered to this as well, and they noted that basically that they could not rule out that the selection bias charge was not altogether true. However, their initial analysis was conditioned on the variables that predicted the loss to follow-up, and informative censoring was unlikely to have substantially biased the overall results. And furthermore, they added strength to their arguments by saying that cohorts have very good recordings of deaths and linkages to death registry, therefore strengthening the findings of those remaining participants who were surviving inside of the study. So all of that being said, in a big mouthful, what was the point of all of this? And did the authors actually accomplish what they set out to do within a statistically sound framework? Were there changes in the 3-year survival and life expectancies of the patients starting combination antiretroviral therapy between 1996 and 2003? Emphatically, yes, there were. Between 1996 and 2010, the life expectancy in 20-year patients starting sort of ART treatments increased by 9% in women, by 9 years, in women, and 10 years in men. They also found that there were substantial declines in mortality for individuals starting ART in the later years, so 2008 to 2010, compared with the other years, resulting in increased life expectancy and reflecting the overall improvement and sort of ART treatments for HIV positive patients. Declines in their mortality were greater for the 2nd and 3rd years after starting ART than when it was for the 1st year, showing that the efficacy of the antiviral treatments basically increased over time. So while the treatments did increase overall survival, a life expectancy for those infected with HIV still did remain lower than that of the general population. So overall, yes, basically survival rates increased, hazard ratios decreased. And whether sort of one can sort of call into question the methodological sort of frameworks used, I think basically even if one did switch to the statistical models that were recommended by the author, the results would have remained the same. The improvements in the care of people living with HIVs since the introduction of antiviral treatments more than 20 years ago have led to vastly improved survival rates and increased life improvements in terms of the availability of superior antiretroviral agents from those originally created 20 years ago, as well as better management of comorbidities for those that are sort of suffering from HIV. And so regardless of the model that one sort of does choose to sort of deploy in doing this, as advancements sort of continue to be made in the area of HIV sort of treatments, the authors also posit that prognostic models and estimates of life expectancy should be updated to account for these improvements as well. So that's it. Thank you very much for your attention.